Right.
Okay, everybody, good morning and welcome to John Henshaw, who is going to be taking us for this session on voluntary assisted dying. Now, we've got some technological issues because John's unable to share what he's doing, so I'm going to be doing that at John's behest, so you will have to be patient with us. Thank you, John.
Okay. Welcome, everyone. I'm John Henshaw. I worked as specialist anaesthetist for 30 years in Ireland, overseas, and in Burney. Because Burney is what we call a base hospital, the anaesthetists are responsible for other areas apart from surgery. We're responsible for resuscitation, responsible for the intensive care unit, and responsible for acute and long-term pain management. So we have quite a broad spectrum of skill sets in that area. I suppose it's my work in intensive care that was the main driver for being able to provide better deaths for people. I've been aware that there have been attempts to introduce voluntary assisted dying in Tasmania for, I think there's been 3 previous attempts. I went to Mike Gaffney's community meeting in Wynyard before coronavirus, and he gave a very good brief of the situation in Tasmania and how his voluntary assisted dying bill could improve the situation. And at that stage, he said he planned to table it in August this year. And I presume that's what's going to happen. So I think things are going to heat up quite markedly. There's really 3 things I'd like to show you. One is a lady, Diane Gray, who died in Tasmania last year, and wrote a diary. And this diary was recorded by her daughter, Jackie. I don't know if it's possible for Reese to play that.
Yeah, I'll do that. Just a minute. So that's the photograph, and then I also have...
That's Diane with her 2 daughters.
Diane Bernadette Gray, 10th of September 1961 to 18th of September 2019. Journal entry, Sunday, 8th of September 2019. Today, I feel the wind, rain and sun on my face for the very last time in my 57 short years of life. I enter the Gibson unit at St John's Hospital in South Hobart and I surrender myself to the elements of the inevitable. With a diagnosis of stage 4 gastric cancer in October 2018, just a short 11 months ago, the deterioration has been drastic in recent months and every bit of life has been torn away from me. The uncontrollable pain and relentless nausea over the last 6 months in particular has been persistent and has used every ounce of energy I have left. It has left me so broken. My family are witnesses of my suffering, just as I am of theirs. Our entire family feels so broken. Cancer took so many of my choices away from me 11 months ago, and now, in the final weeks of my life, I have no choice other than to accept my torturous fate. I can accept dying. I cannot accept dying a slow death in intolerable pain. This pain in itself has me wishing nothing more than to die and to end my own suffering. I want my daughters to remember me as I am, and I want beautiful, lasting, final memories. Would you believe I felt my only way out was suicide? You left me no choice to openly discuss this with my daughters. It wasn't the fear of dying early by suicide that deterred me, but the fear of dying alone and not surrounded by pure love and in the arms of my loved ones. I've witnessed some bedside rituals in the past, and I wholeheartedly know I do not want that for myself, my partner, or for my daughters. I know they will not leave me until I take my last breath, and I know how soul-destroying and torturous this can be, with the feeling of such helplessness and watching on while the person moves through the stages of death, more so when uncontrollable pain is involved. I want to slip away under my terms and allow my children to have a final goodbye, not to be tortured for weeks of watching me suffer and lose every ounce of dignity I have left. After 11 months of hell and torture, surely I deserve at least this. During the course of the 11 months, I visited hospitals on more than 10 occasions in an attempt to control my pain and nausea, but you know what? We never had it controlled to a tolerable level. This extreme pain and nausea has taken away nearly every piece of happiness I have left, and I am now a mere shadow of my former self, physically and emotionally. If I cannot choose to end my own suffering, who exactly owns my body? How is it that families of patients who are being kept alive by technology and machines can have a choice to stop all medical interventions, but I do not? We do not allow animals to withstand chronic pain. However, we expect our family and friends and for me to bear this excruciating agony. I pray you and your families will never have to endure a situation similar to ours, but in reality, unless you do, you'll never have enough understanding or empathy to help legalise voluntary assisted dying in Tasmania. Sit with me during the last few days of my life, look me in the eyes, deny me of ending my suffering while my withered away body convulses in pain. There is nothing humane about this ending. This is not my life or my body anymore. I am a shell, and you have taken control of me. Let us live the last chapter of our lives fearlessly, knowing we can end our own suffering and despair. There is a difference between suicide and voluntary assisted dying. I do not want to die. I am dying.
That's very poignant, absolutely poignant, and that is certainly a picture of the situation for probably about 5% of people who are dying in Tasmania. Is it possible to put up the news clip one, Reese?
Yes, okay.
If that's possible.
Thousands of people are throwing their support behind the family of 61-year-old mother of three who became the first person in Victoria to end her life under the state's voluntary assisted dying laws. Carrie-Anne Greenbank reports. Well, Victoria's state government has revealed a number of people are now going through the process of being legally allowed to end their own lives after the assisted dying legislation came in on June 19. Less than a month later, Bendigo mother Kerry Robertson was the first person to take up the scheme. Today, her daughter spoke publicly about their mother and her choice after a 9-year battle with cancer.
She not only had lesions on her bones, there were tumours in her brain, in her liver, in her lungs. It was very extensive. There was absolutely no doubt in her mind that this is what she wanted. It's not about political agenda or religion. It's about human suffering and ending that suffering.
13 members of the Assisted Dying Review Board analysed all the details of Kerry's case and saying her death fully complied with the legislation. The Health Minister says 250 doctors have now been trained or are completing training to be involved with the scheme in the future.
It's heartening to me to see the fact that we've got 250 doctors in Victoria who are in the process of completing that training. And hopefully those numbers will keep going up.
Doesn't change the fact that I've got deep empathy and my heart goes out to Kerry Robertson and her daughters. But in terms of VAD, my view hasn't changed. I think in some ways this normalises suicide.
The new laws remain controversial. Some doctors are set against it, but they're also being considered in Western Australia and Queensland. Victoria anticipates up to 150 people who meet all the criteria, including only having 6 months left to live, will be taking up the legislation every year in the future.
That gives you an idea of the situation that's available now in Victoria.
People are throwing their support behind the fact.
Sorry, John, I'm trying to.
No, you're right. So that Karen, that lady, was able to die with her daughters with her, a peaceful and non-stressful end, which her daughters obviously are very happy that she was able to do that. And that's the contrast between before, or the situation currently in Tasmania, which Diane had to go through, and the situation now in Victoria with voluntary assisted dying that Karen was able to take advantage of. Is it possible to play the Nick Carr one? That'll be the last one.
It was possible. It doesn't matter. I'll just.
It's not the end of the world.
No, not at the moment. I can have a fiddle while you're doing stuff.
Okay. Right, and we may be able to show you a video of Dr. Nick Carr, who is one of the, he's a GP in St Kilda, and he was one of the first doctors to do the prescribed training for voluntary assisted dying doctors in Victoria. And he's assisted patients for about 20 occasions when he'd done the video, and he's responsible for training other doctors. And he makes a very potent point, which is that although he's been involved with quite a lot of patients who've applied and been accepted into the VAD scheme, not all of them have used the medication to die.
I've got it up there, John.
Okay.
Hi, my name's Dr. Nick Carr.
Can people see that, or are you still seeing John?
The sound is fine. Don't worry about it.
Okay.
Doctors trained to provide voluntary assisted dying care here in Melbourne. So I just wanted to let you guys in Tasmania know what the experience has been like, because you're going through the debate at the moment. And people have some understandable concerns about whether this will work, whether it'll work safely. So we've had the law in place here in Victoria now for over 12 months, and it's been a revelation really about how this has worked, because what's happened is that a relatively small number of people, so it's only a few hundred, have applied to have this kind of care, and the experience of those people has overwhelmingly been incredible relief at being given an option that was previously denied to them. Many of those people haven't gone on through the process to use the medication. Just starting the process, knowing that they had that as a possibility, has made an enormous difference to their end-of-life suffering, knowing that they regained some control over the end of their lives. For the people who have gone through the process, and I've been there for a number of people who've taken the medication, it has been, it sounds odd really to describe dying as beautiful, but it has actually been a beautiful experience. It's been so calm, it's been so peaceful, it's been a positive experience. Rather extraordinary to say that, but it has been a positive experience for myself as a doctor, and the families generally have described it that way too. Their loved ones were going to die anyway, but in the end they died comfortably and in a way that was very gentle. On the cases where it's been what's called a practitioner administration, where I've had to give the medications, again, I've been astonished by how very gentle, very peaceful, and how appropriate it was for the family who could say goodbye to their loved one, be there at the end, and the process has gone extraordinarily well. The most important part about this is it's only applied to a very small number of people, and for the rest of the world, life has just carried on. I mean, the sky hasn't fallen in. Nursing homes haven't been emptied of people who've been coerced into having this done. There's no coercion. You can't coerce older people into going through this process, and that's what the laws protect against anyway. And for the practitioners involved, it's overwhelmingly been a positive experience. So you Tasmanians, if you're supportive of the legislation coming up, I would really strongly encourage you to go out and sign the e-petition and take part and support the carriage of this bill. It's been a very positive thing for Victoria. I hope you'll get it through in Tasmania and find that the same is true in Tasmania. Best of luck.
Thanks very much. Thanks, Reece, for that. He says it all. There's nothing I can add. Just to reinforce the fact that the very fact that people have that choice available can enable them to die in comfort and dignity. They may or they may not require the medication to die peacefully. The Victoria legislation's been in since June the 19th last year. In the first 6 months, 150 people were accepted into the scheme, and 52 of those use the medication, so one third. Whether it will stay that sort of ratio because it's early days yet, but that's the current situation in Victoria.
How many of the other 100 have died, John, without the medication?
I haven't got those figures.
Because that would be interesting to know who.
Yeah, no, it would be. Yeah, it would be. I think you could probably, as a guesstimate, you could probably say that at least half of them would have died. As a guesstimate. It's been introduced. The legislation's been introduced in WA, and that was pre-COVID, so that was Christmas, New Year time. There's a referendum in association with the New Zealand general election, which, if the referendum's passed, New Zealand will have voluntary assisted dying. And depending on the outcome of the election in Queensland, a bill will be introduced in Queensland. So that's the current state of play in this part of the world. I just want to talk about what actually happens, and then we can go into the sort of more nuts and bolts of the procedures involved. What medicine is used to assist someone to die? If you Google it, you won't get an answer, a direct answer, and the state governments don't list medications used. In Victoria, all the medications are done through the pharmacy in the Austin Hospital. So it's done in a centralised public hospital pharmacy, and then it's distributed as needed. And hopefully, if the legislation gets up in Tasmania, it will be done through the pharmacy in the Royal Hobart Hospital, done centrally and not any other way. The medication that's used, there's 3 elements to it. One is an antiemetic medication, which is known as ondansetron, and that is given to the patient takes that an hour before they take the other 2 medications. And that's to relieve nausea and to reduce the likelihood of vomiting. And then after an hour, they take 2 medications, one of which is a sedative, a class of drugs related to Valium, benzodiazepine drugs, which make you very sleepy. And the other is a morphine type drug. which depresses your breathing and obviously reduces pain. And the combination of the two in the dosage that's approved will mean you'll slip into unconsciousness, and gradually your breathing will slow, and eventually your heart will stop because of lack of oxygen. But there is no distress in this. The body isn't fighting for breath. So people die peacefully. And then the death, these people are already registered and known to the register of the assisted dying board, and the death is then reported to the coroner. So that's the actual medication that's used. Now, sometimes people can take the medication themselves, just like we take our ordinary medication. Sometimes people are not able to swallow, and this is particularly people with neurological conditions. Motor neuron disease is the big one. And they often have feeding tubes, either often at that stage directly into the stomach. And the medicine can be administered as a liquid into the stomach through the feeding tube. And the patient can be assisted with that by the doctor who is present at the death. And then there are another group of patients who cannot take anything internally, and the medication has to be administered intravenously. And again, the doctor does that, administers it intravenously. But the medications are the same, and the peacefulness of the death is the same. And usually you're talking about an hour or so for the person to die. So that's the medication that's used. The mechanics of the bill. I talked to Mike Gaffney when he was in Wynyard, and he's very enthusiastic with his bill, obviously. He's made a number of changes before it's got to the stage it is now. If Victoria and WA are anything to go by, more changes will be made. But I can run you through basically what happens, and interrupt me whenever you want. Basically what happens is
John,
yeah?
it's Joe speaking. Before you
Hi.
go on, just to go back to the medication, is the medication consistent in every state and internationally?
Certainly in Australia it is. It's basically consistent. The drugs that are used, every drug belongs to a family of drugs. So one may use one type of sedative, another use another type of sedative. One may use one type of morphine, another that, and different antiemetics. But no, it's the same. It's completely different from putting people to death by lethal injection. Completely different. When you put someone to death by lethal injection, you're meant to put them to sleep. Sometimes they haven't quite got that right because there's no doctor involved at all. But you give people then a medicine to stop their heart beating, which is usually a potassium medicine. So you put them to sleep and you stop their heart beating deliberately. So they will die, they should die within a couple of minutes. There doesn't always work out like that, unfortunately. But with voluntary assisted dying, you are not stopping someone's heart directly. What's happening is they're going to a deeper and deeper and deeper sleep. Their breathing is getting slower and slower and slower. They'll eventually not get enough oxygen to keep their heart beating, and their blood pressure will fall and the heart won't pump as well. But it's a slower, more peaceful process. So you're not deliberately stopping their heart. It mimics basically what happens end stage when people die, except without the distress. So with Mike's, can you hear me?
Yep.
Yeah. With Mike's bill, it's complicated. But basically what happens is a person, and one thing that is in all these bills is the person has to initiate it, not the doctor. So the person comes to see their doctor and asks if they're eligible for voluntary assisted dying. And the doctor provides them with information and discusses it with them. And then they go away. And then they come back to the doctor and request that they join the voluntary assisted dying scheme. They be approved for it. And if the doctor thinks that the patient is appropriate for that, then he will say to the patient he thinks they're appropriate, but they've got to have a 48-hour cooling off period. And then they can approach the doctor again and request again that they be considered for the scheme. And if the doctor again thinks they're eligible, he then needs to refer the patient to a consulting doctor, another doctor, an independent doctor.
Excuse me, John.
Yeah.
Question, is it necessary for other family to be involved in this?
Other family are involved with this, obviously, but it's the patient who's got to initiate it, and it's the patient who's got to be eligible, and there's conditions about being eligible, which I'll discuss in a little while.
Now, do you mean that if a family member disagrees, that, or is that because that's
if a family member disagrees, a family member disagrees, but providing the patient agrees, that doesn't matter.
good? Yep.
It's autonomy. We're responsible for ourselves. No one else can take that over unless we're incapable. So yeah, that's the situation.
And just as a side issue to Mal's question, what if the person is non-verbal or unable to speak or write?
I'll come for that in a minute, okay? Because that's another issue. Right, so we're at the stage now where the patient's been referred to another doctor, a consulting doctor. In Victoria, they've got to be a specialist, they've got to have done a certain number of years, and they're supposed to have a knowledge of the disease that the patient is suffering from. There's issues with that, and I'll come back to these issues. If the consulting doctor, the second doctor, agrees that the patient is eligible and fits the criteria, then the patient can go back to their original doctor and make a final request to be admitted to the scheme. And then if everyone's happy, they get admitted to the scheme. And what happens then is a prescription is generated to the central pharmacy, and a package is made up of the medications. There's a couple of things here, and it's the way the legislation is proposed legislation is written. But the first doctor is called the primary medical practitioner. The second doctor is a consulting medical practitioner. And then there is a third person who doesn't have to be a doctor in my reading of the bill, who is called the administrating health practitioner. Now, if you're lucky and you've got an agreeable local doctor, your primary doctor, the person you went to first of all, can also be the administrating health professional. So he can be the person you deal with all the way through and will be there at the end. But if that's not possible, if he's not trained, then that administrating health professional can be someone else who is trained. So that brings a third person into the picture, which is just the way of the world. And then the person then has to give their final permission when they've decided that this is what they want to do, because as Nick Carr said, excuse me, there's a good proportion of people who never take the medication for whatever reason. But if they give final permission, then they're able to take the medication. But the administrating health professional has to know about it. So you don't just sort of randomly do it. You need to say that this is what we're going to do, so that someone can be present to confirm death and to see there's no funny business going on. And then after death, there's a registrar who's in charge of the administrative side of things. And the registrar is notified and the coroner is notified. And the coroner, if the coroner should, because the registrar knows about this, be quite happy with the situation. But obviously, the coroner's always got to be notified about, I don't know how you can put this probably. I was going to say unplanned deaths, but they're planned deaths. But the coroner's got to be notified about it. So that's basically the way it works. There's issues here. One is, what if your doctor doesn't want to do anything to do with it? Well, hopefully he will refer you to someone who's prepared to get involved in it. But if not, you should be able to contact the registrar and find someone who is trained or familiar with voluntary assisted dying.
Will there be a register of doctors?
There will be. There is in Victoria. The health minister on that little video clip was saying that they've got 230 doctors who are trained in the legislation and the mechanics of voluntary assisted dying. And if it's introduced, if it's passed in Tasmania, a similar scheme will operate here. So you have training sessions for doctors who wish to take part. The consulting medical practitioner, both with the primary medical practitioner and the consultant medical practitioner, they usually got to be in practice for more than 5 years. In Victoria, they've got to be have a knowledge of the disease that the patient is dying from. Because you've got to remember, all these patients are already dying in some way or another. There's issues with that, particularly in Victoria with motor neuron disease, because what they would say, or what has been said, is, oh, you need a neurologist. Well, neurologists are pretty thin on the ground, and that can be technically difficult. There's another difficulty, which applies mainly to the consulting medical doctor, in that you have to have a face-to-face meeting with the patient. And obviously, if the patient lives in Mildura and the neurologist is in Frankston, that's technically difficult. It was originally thought we could do that. This could be done over Zoom, Zoom type arrangements, but the fly in the ointment is the Commonwealth, because all what do you call it, telephone, internet,
Video
mail,
conferencing.
is under the control of the Commonwealth, because it's listed as what they call a carriage service in the Constitution. So the Commonwealth has responsibility for this. Currently, Commonwealth law states that it's an offence to encourage someone to take their life. And the problem is, because of the current, well, it is to a certain extent political. The current Commonwealth government is not prepared to set the current Attorney General, Christian Porter, is not prepared to say that this will be an exempt procedure. So nothing can be done over the phone or with internet, which makes it more difficult, particularly for people in this situation. But that's something hopefully will be addressed in the future. And you have to determine if the patient's eligible. There's 3 aspects to eligibility. One is residence. So in Victoria and with the Tasmanian proposed legislation, you've got to be resident in Tasmania for 12 months. You don't have to be a citizen, you don't have to be a permanent resident. But if you're not a citizen or permanent resident, you've got to be present in Australia for 3 years and Tasmania for 1 year. So that's residence. You've got to be over 18. You've got to have a diagnosis. So when you apply for assisted dying, the doctor's got to be able to say this person has terminal breast cancer, lung cancer, motor neurone disease. You've got to have a label, basically, so that the registrar can then look down his list and say, yeah, this is an appropriate thing. And then the final thing is you've got to be able to give consent. And that means that you yourself have got to be mentally competent to give consent to the scheme. Now, if you're non-verbal, or that's not an issue because you can indicate your consent non-verbally, but you've got to be you've got to have the cognitive awareness to be able to make that decision. And this is where another area that can cause difficulty. If you think about the diagnosis of dementia, I mean, there's lots of ways you diagnose dementia, but the simple things like there's the mini mental state examination, which takes about 10 minutes, which is, where do you live, what year it is, spell a word backwards, those sorts of things, which give you a reasonable idea of someone's cognitive state, if they're verbal. The other thing is what's called the activities of daily living. So if a person can dress themselves, wash themselves, toilet themselves, feed themselves, there's a good chance that they're cognitively okay. The problem, of course, is with more advanced dementia, and there you cannot say that someone is cognitively aware, and therefore they would be ineligible for the assisted dying scheme. The grey area, of course, is people who are becoming demented and still have some cognitive ability, and whether they can make an application while they still have some cognitive ability for application of the scheme down the track, and that will be argued over, as it was in Victoria. One with the diagnosis in Victoria, it is in the legislation is you're expected to die within 6 months. Now I can't find that in the in Mike Gaffney's legislation. It just talks about end of life, severe, unmanageable symptoms, and in that sort of language, but doesn't talk about a time period. And obviously, time periods are nice for lawyers, but it's meaningless for the patient. It's meaningless for the medical practitioners. It's just nonsensical. So if you're talking in, and interrupt because I don't want to ramble on, but when you're thinking about who's eligible, motor neuron people and people with severe neurological disabilities who are beginning to have difficulties with swallowing and difficulties with coughing and some shortness of breath. When you're at that stage, you'd be eligible because it's likely you'll be dead within 6 months. You may live longer, some people do, but it's likely you're going to be dead within 6 months. And death will not be good. It will be very difficult for you. People that have major cancers, who have had a relapse, either diagnosed initially with a major cancer, or they've had, say, breast cancer, had treatment, and gone on okay, but then 2 years, 5 years, 10 years later, have a relapse and spread of the cancer. So
What
then
about-
you
What about people that have something like cancer and refuse treatment? Does that negate? So they're going to die because they're not being treated?
no, that doesn't negate it because you can't force anyone to have treatment. But I think what would happen is if you went, say, use breast cancer as an example, you had breast cancer and you didn't want any treatment. Well, if you've got localized breast cancer, you're not about to die, and you may live on for, depending on the aggressiveness of the breast cancer, you may live months, you may live years. So I think at that stage what would happen, and this is me thinking, this is not written down in legislation.
Yeah, it's just conjectural. Yep.
Is that the doctor would say, look, you're going to have to wait and come back when the cancer spread. It sounds awful, but so you're going from a stage 1 cancer, which is localized, to a stage 3 or 4 cancer, which is, well, certainly a stage 4 cancer is widespread. So you've got metastases in the bones, liver, whatever. So certainly at that stage, even if you hadn't had any treatment, you would be eligible for consideration for VAD.
Mm-hmm. Thank you.
That's basically the bones of it. There's a couple of issues with the bill itself, one of which is the fact that it's sort of been done from the bottom up in Tasmania, and most medical health professionals, or a lot of health professionals anyway, let's put it that way, and probably a lot of lawyers, think that it would have been a million times easier to use Victorian legislation, because that's been through the ringer, and has been passed and has been working for a year. Whereas this hasn't been subject to that sort of scrutiny, and it will be, and it will, every little bit of it will be dissected to the nth degree.
John, Joe here. Do you know why Mike Gaffney took, or those big supporters of developers of the bill took the direction they did and not based this Tasmanian bill on the Victorian one?
No clear answer to that. I think Mike thought it might be an easier go if it was done here. It would there might be less opposition to it if it was done here. But the problem with that is I've read through most of the bill. It's 150 pages long. It's very legal in some ways. You have a sentence which has the word person in it 5 times, and the person is not one person, it's the patient and the registrar and the primary doctor. So that's the sort of legalese of it. Yeah, but that it is, as they say, it is what it is, and it's what we've got, and it has been modified from the beginning of the year because Mike did the community meetings, and then he's met with health professionals and met with other lawyers, and certainly the health professionals and the doctors have said that certain things need to be tightened up. An example of this was there was mention of minors in the original proposed legislation, and that would be an absolute red rag to a bull. Any mention of minors would have, well, certainly most politicians crashing down on it. So you don't go there. That's something that you can address maybe in 5 years' time or 3 years' time when the thing's up running and everything else. But you don't go there in the beginning. Certain things like that, which, you know, the Victorian legislation, it's been spring cleaned, I suppose, to get rid of those things.
Jen has a question.
Sorry?
Jen?
John, I was wondering, what are the fundamental, or if there are any, differences between what's being legislated here in or going to be legislated here in Tasmania and that which has already started in Victoria?
There's no fundamental difference. I mean, the aim is the same. The details are different. For instance, in the proposed legislation here, there's no requirement that the consulting medical practitioner be a specialist with knowledge of the disease that the patient is suffering. But that's in the Victorian legislation. And it was a key element, I think, in the Victorian legislation. So that may become now, obviously the bill can be amended,
Yes.
but I think that will be an issue. There's no mention of time frame, and it's good that there's no mention of time frame, but Mike may be forced to put in a time frame. That's a couple of things. And the other thing is just the way it's worded. I'll give you an example of this from my own experience. I was one of the people who was arrested in Laponia for the logging there, and we were charged under the new workplace, whatever they call it, disruption, something. The new law that they brought in 2017 or 16 to stop people protesting, and well, we went to court 2 times and then the case was dropped. And the reason the case was dropped was because the legislation was not right. It wasn't worded correctly. It wasn't precise. It was vague. And eventually Bob Brown took it to the High Court, and the whole thing was thrown out. And the public prosecutor realised there was no future in it, and abandoned any further proceedings. And the problem there, of course, is you've got a small group of people drafting legislation in Tasmania, whereas in Victoria you've got, you know, a much bigger, probably tighter ship doing it. Is the legislation that's produced in Tasmania tends to be overtly wordy for no good reason, but that's a technical legal thing. But there are some things that have been corrected already, but there are some other things that will be sticking points, and the consulting second opinion doctor will be a sticking point, I think. The administrating health professional who doesn't need to be a doctor, I think that may be a sticking point, and there may be other sticking points. But with goodwill, of course, all these things can be got round.
Edna. Don't forget to unmute yourself, Edna. Bottom left-hand corner.
Thank you. John, just going back to the procedure. That might, just a sec.
While Edna's getting herself organised, Mary wanted to say something.
Hello, John. I got here after all.
Good on you.
I just want to say that like John, I'm a retired anaesthetist. I belong to Dying with Dignity in Tasmania and to Doctors for Assisted Suicide, which is the national body. I'm delighted that John has stood up to be counted. I did go through the whole final version of the bill. I agree with all the clumsy things which John has mentioned, but it's our last chance now for years to get this through in Tasmania, and we hope it'll be changed so it's not quite so clumsy, but the main points are really very worthwhile. Just 2 points I wanted to bring out. One is, and it's emphasised in the bill, that medically assisted death is not suicide. And although suicide is not a crime now in Tasmania, possibly someone who encourages somebody or helps someone to suicide can be under legal duress. So it isn't suicide. But still, we're very clumsy ourselves. People still talk about committing suicide. So that's one point, is that it's not suicide. The other point is that much as I support palliative care, there are situations where it has failed, and failed very recently in a care home. Assisted palliative care available, all the forms signed, and oh yes, he is having palliative care. But this resulted in a terrible death, an appalling death, with the partner not there. She wasn't notified that he was dying, and he died in terror and unrelieved pain. So we must admit that sometimes palliative care, which can be marvellous, does fail. So please, if you can support this bill, do. I'm personally about to write to every member of the Legislative Council. I think personal submissions, as well as signing the appeal form, is something which we can all do as individuals. So thank you, John.
Thank you, Mary.
Edna, your question now. Don't forget to unmute yourself again.
Got it.
Yep, beautiful.
Just wanted to ask back at the actual procedure. During the time it starts to when it finishes, how long does the patient have time for talking if they can talk and communicate with the family, or do they drift away very fast?
It depends obviously on the condition of the patient, because some patients may be very near death anyway. But yeah, you'd be probably talking about 15 minutes, 15, 20 minutes, something like that. Then they become unconscious and then become unresponsive and then they die. And usually over an hour, that would happen usually.
Right. Thank you.
It's well refined. And another thing that's been raised is, that's my wife going out. Another thing that's been raised is dosages of medicine. It's a standard dose for everyone. That you don't worry about the patient's weight or anything like that. It's calculated on people's lean muscle mass, and which is pretty much the same for males and females when they're aged or ill. So it's a standard dose for everyone. I'd like to just, as Mary was talking about palliative care, are you happy with that, or can I add to that?
Yes, please do.
Yes, please.
Right. As Mary was saying about palliative care and dying, and there's a thing known as terminal sedation, which is aimed to relieve the symptoms of distress in dying. There's problems though, and I'll just go through a little checklist. Terminal sedation, we call that TS, and voluntary assisted dying, we call that VAD. With TS, dying can be prolonged and uncertain. With VAD, dying is quick and it's certain. With TS, the decision is often made by the doctor. With VAD, it's always made by the patient. With TS, death is often experienced by loved ones as undignified and harrowing. With VAD, it's experienced peacefully. With TS, the time of death is indeterminate, so you don't know exactly when the patient's going to die. With VAD, you know when the patient's going to die. It's arranged, it's planned ahead. With TS, deep sedation can remove your sense of person and consciousness. But with VAD, consciousness is preserved till you go to sleep, and dying is reasonably quick. There's problems with documentation in TS, with accountability, with legal protection, with access, capacity, and then finally, I suppose the big thing is terminal sedation doesn't bring anything to the party of dying, whereas VAD, dying is good. You die with your loved ones, you die peacefully, you die planned, you die the way you want to die, you die where you want to die, you die in the manner in which you want to die. And when you're gone, your family know that's the way you died, and we're there to be with you when you died. The grief and distress of unplanned and painful deaths is tremendous, and it causes a lot of distress to partners and family. But you've got to remember that most people, that's not the way for most people. Most people have reasonable deaths, but there is a stubborn section of the population who die very unpleasant deaths in spite of people trying to do the best for them.
John, what's the comparison between VAD and a family with a loved one on life support and making a decision whether to turn the life support off or not?
That's a different thing. It's really a different thing entirely. When someone's on life support, there's two things there basically. When you decide to remove life support, and this is where having wills and all that sort of stuff come into play. But basically, the doctors will say that there's no future. Because of the injury, illness, whatever, or what's happened to the patient. So if you turn the life support off, there's two scenarios. One is the patient's already brain dead. So if someone's had, say, a severe head injury from a motor vehicle accident, you can do tests to determine that there's no brain function. The heart may still beat, but there's no brain function. So that's the definition of death. There's no brain function. So all you're doing then basically is keeping a body pumping blood around. You're not doing anything else. And then the other ones are where the illness is so great, or the injury is so great that although if you, because these people are usually sedated and quite heavily sedated. If you stopped all the sedation, they would wake up, but they would die, but they die in distress. So that's basically the situation there. So turning off the life support, basically you have a VAD death. Because you can plan it, you can say, we're going to turn the life support off at 8 o'clock tomorrow morning. Can all the family come? We'll arrange the bed situation so they can sit and play music or hold hands or do all that sort of stuff. Turn off all the BP machines and just let them go.
But it just seems that that's an accepted right of the family to make a decision in that case.
It's the right of the family to make a decision for. It's the right of the family to make that decision, but the family doesn't have the absolute say, because it doesn't usually get difficult. Usually, most people can see what we call the bleeding obvious, that their loved one is going to die.
That's what I was thinking, though, John. It seems like that has been an accepted way to relieve a person of, continuing for no purpose, and yet VAD has to go through so many complications of different tiers of input from medical staff, etc., and is still under question across Australia. Basically, so it seems like there's an extreme difference in those two means of a careful death.
Yeah, the perception is different, and I suppose it's the monotheist background that still exists, where suicide is not suicide-assisted dying is not has not been seen. It's the suffering you have, so you cleanse your sins and go straight to heaven type thing. That's the argument that used to be made in the past. We all have to, like the way they used to say, you have to suffer in childbirth. And and then you've got to suffer dying so that you can go on to your heaven in a state of grace. But those ideas are in the minority now, I would say. And the other thing is, I mean, there is a growing momentum. I mean, Vic and WA have gone down that track. It's very likely New Zealand to go down that track in October. If the present Queensland government hangs on in the election, it's very likely Queensland will go down that track. But there's a lot of people who are going to make a lot of noise. I've got a thing here from good old Eric. End of life choices bill is state sanctioned suicide. That's what he said. And that's a man who's, I mean, I'm not getting personal, but that's a man whose wife died from advanced breast cancer less than a year ago. But obviously everyone's circumstance is different and everyone has their beliefs, and we have to respect that. Obviously we do. But because one person has beliefs doesn't make their beliefs any more important than the next person, if it's done properly and doesn't involve forcing people to do things and it's done. That's why you've got to have legislation. That's why we have to go down this path. But I think, as Nick Carr said, you know, the world doesn't fall, the earth doesn't fall in. Life goes on. It's not something that's needed by everyone. It's needed by a minority of people, but the people who need it, and that's we all know people, well, I imagine at our stage of life, we all know people who have died miserable deaths, and you wouldn't wish it on your dog. There's ways in which that can be avoided, and hopefully that will happen in Tasmania before the end of the year, hopefully.
Irene,
Can I have a
question?
John, I'm unmuted, aren't I?
Yes.
No, I can hear you.
Sorry, John. Can you hear me?
Yes, I can hear you fine. Yeah.
Sorry, I'm seeing Reese.
I can hear you. Yeah.
Oh, okay, I've got two questions actually. When you take a loved animal to a vet, they put that animal to sleep in front of you. It's very quick and painless. They go into a sleep and pass away in front of you. You can, so why is that not available for people? And secondly, if you've had a loved one go through a terrible death and you've set up a medical guardianship for someone to have your say, you know, I've set up my son with all my wishes by the solicitor, that, you know, the end of life and different things. Can that come into play if I'm unable to, you know, if I'm non-compass?
Do the second one first, and the answer is no. And the reason why it's no in the current situation is you have to give consent at the time. And that's the reason why. So you cannot say, you can't put in your will, I want to avail of voluntary assisted dying on the basis that I may get cancer, I may get dementia, and it be done. You've got to be able to give consent at the time. So that's the crucial difference. And that's the problem with dementia. There is a clause in most of the legislation, and there is in Mike's, that speeds up the time frame a bit. You've got to give consent about four or five times if you're eligible for assisted dying, and there's a gap between each consent. So we're talking about this going over several weeks often, or a couple of weeks. That can be speeded up if it's thought that either death is imminent, or the person's cognitive ability is likely to decline, so they won't be able to give consent if you hang on. But beyond that, you can't make a wish down the track if you're not then able to give consent. You can, I mean, obviously you can put these things in your, as a codicil to your will or instructions to your family. But you at the time, you'll have to be able to give consent. So that's the crucial difference. And I think it would be impossible to get a bill passed that didn't have that in at the moment. I mean, things change, and 20 years down the track, if it's going, things are different. Vis-a-vis the dogs, while you're doing it to the dog's not doing it to himself. The other thing is it's either intravenous or subcutaneous into an area with big blood supply. So the drugs are going to the brain and the heart very quickly. That's what happens. I mean, if you're administering the VAD medicines to a patient by injection, which sometimes happens, it's part of the part of the package. It's one way of giving the medication if someone's not capable of absorbing it. There are ways in which you could speed up the death, but it's not done that way. You just do it gently, and it ends up being, it'll be quicker than taking the medicine orally, but it's not like you're dead in a minute or whatever. And that's just the way it is. Yeah.
But it's still a peaceful.
Oh yeah, peaceful. I mean, I have a friend of a friend who had motor neuron disease and died in the Alfred Hospital. In she was a nurse. She'd signed up for VAD, but she wanted to hang on to her mother. Came over from Scotland. So I mean, she got to a stage where probably most people would have said, you know, go for it, don't hang on. But she did hang on till her mum came over from Scotland, and when she came over, she was pretty bad. And after she'd met up with her mum, they gave her the injection of the assisted dying medication in the Alfred Hospital.
Thank you.
Any other questions, anybody?
Has there ever been a case in Victoria where the morphine didn't actually completely work and had to have another dose of morphine to complete the assisted dying?
It's done in a dosage that is certain to work. So, I mean, no one can never, you can never say never in anything in this world, and batches, but the chance of it not working is minimalistic. But one of the reasons for having an administering health professional there is, one, to confirm death, but two, if there's any difficulties, to sort them out straight away. I mean, you could drop the medicines, you could be injecting it into the patient's feeding tube and it spills out or something like that could happen, obviously, and there'd be provisions for that. Yeah.
Mel, you had a question?
Yeah. John, it's Mel, the Silhouette, speaking here. This is somewhat a step aside, but if it's in your will that for whatever reason of illness or trauma that you don't want life-sustaining medication issued, is that enforceable in Tasmania? Pardon me.
Yeah. Oh yeah. If it's in your will, then it's enforceable. That's why it's important to have a will with those sorts of things put in. I mean, one of the joys occasionally in the hospital dealing with people who were seriously ill was that they'd made their feelings clear, and they did not want to go on assisted life support. They did not want to be resuscitated if their heart stopped. And providing that there's two sides to it. One is that that's what they want. The other thing, of course, is that they talk to their family, because as soon as you're unconscious, it's the family that's going to do the talking for you. And unless someone can run around and grab hold of a willing read it out to you, which is often not the case in these circumstances, there and then, the family have the say. So you do need to be very upfront with your family about what you want. And if you are, that's fine. But of course, the other, and to be upfront about who your next of kin is, who's speaking for you, because obviously family involves quite a lot of people, and often someone comes out of the woodwork with a different view for some reason or other, which causes a lot of angst. But yeah, we all know that.
Anybody else have a question? No? Okay.
Thank you.
John, what are the prospects of this legislation? Somebody must have done some numbers. And secondly, you said about writing to members. Is that something those of us who choose to do, could do as well?
Yeah, it's always helpful, particularly your local member. I'm not so sure if it's worth writing to people outside your area, but it depends on what you feel like. Basically, the way the numbers go at the moment, the Labour support it, Greens support it, and there was a thing in the Advocate on Saturday doing a split of the Legislative Assembly, and there it looks like there's a good chance of it being supported.
That's what I'm holding up, if people can see.
Yeah, that's it. I mean, there's a couple of them said yes, and then there's some that said they support it in principle, which means that they're willing to support it, but they may need some amendments. I think if they support it in principle, they're basically saying that if it was the Victorian legislation, they would support it entirely, but they want to see what tweaking they want to do with it. And then obviously there's people who don't support it, and they're never going to support it, and that's the way of the world. But it looks like they're, with goodwill, it will get through the upper house, and then it goes to the lower house, and that's where the trouble is. Because if it's a free vote, the Labour will support it, the Greens will support it, Sue Hickey will support it. If it goes for a free vote, then it's probably likely to go through, because, yeah, hopefully it will go through if it goes to a free vote. And what you really want is a couple of the senior Liberals to support it, because the Christian right-wing side of the Liberal Party will come down like a ton of bricks on people, on Liberal members who support this bill. But if it's a senior member, they've got the clout to say, pull your head in. This is the way it's going. So the deputy Rockcliffe. I mean, he's said in the past that he is supportive of legislation. He's voted against previous bills, but if it's done properly, he says he's supportive. And he certainly could stand up to the hard right, the Abetzes of the world. But yeah, remains to be seen. But there is a move with Victoria, WA, and hopefully New Zealand. But of course, they're all Labour governments. And this legislation hasn't been passed by any Liberal government in Australia yet. But we'll see what happens.
Yeah, okay.
We're all very hopeful. But yeah, I think talking of writing to your local person.
We'll send out to people who want it through the U3A. We'll send out that list of the MLCs and the website you can get the addresses from if people want us to write. Edna, did you want to say something? Unmute yourself. Bottom left-hand corner.
I didn't want to say anything. I was just scratching my head.
Oh, okay.
That's all right. Good on you.
John, if I can jump in here for just for a moment.
Yeah.
There was mention of an online petition or something similar. Do you have details of that?
I don't. I imagine it's. Oh God. I'll try and find out. Yeah.
Mary sitting next to me says we can get it, and we'll send that out along on the email that we send out, Frank, with the addresses, the MLC one.
No, that's great. Thank you.
I did find it quite easily.
Yes.
Yeah, just Google.
Yeah. Okay. Well, thank you, John, for we're probably all converts, which is the only problem with this.
Yeah. I know that. But I think most people are. I think most people in the state. There's not many people that haven't experienced a relative die, and in whatever way they die, they realise there's a total loss of control. And I think a lot of people would like to be back in control.
Yeah, and there's always, every time there's a survey done, there's always an overwhelming support for VAD. So yeah. Mm-hmm. But anyway, thank you very much for this morning. I really appreciate it. And,
thank you, John.
Thanks, Mary.
Okay. And thanks, Reese, for doing the videos. Thanks a lot.
No worries.